Welcome back to Rad Onc Smart Review GU Cancer Series.
Got to be here for this one.
Yeah, I'm your examiner for today, and this is episode 12, Case-Based Review, Prostate Cancer Mock Oral Boards.
The dreaded hot seat.
Exactly. I mean, imagine you're treating a patient, right? You bring them through weeks of therapy, you get that undetectable PSA, and you send them home seemingly cured.
Best feeling in the world.
Right, but then you see that number creep up 2 years later by just, a fraction of a decimal point.
Yeah, it changes everything.
It really does. Suddenly, you are no longer just treating a localized tumor, you are fighting a systemic war. So, today we are diving into those exact high-stakes decisions.
Tracing the whole lifespan of prostate cancer management, basically.
Spot on. So let's lay out the ground rules for today. This is a dedicated mock oral board session. I will be in the role of the examiner, obviously.
And I'll be the resident examinee, trying not to sweat too much.
You'll do fine. Now, for those of you listening at home or, at the gym or on your commute, I strongly encourage you to pause the audio after each of my questions.
Yeah, you really have to formulate your own structured response out loud. Speak it into the room.
Right, don't just think it, speak it. Then unpause and listen to how we break down the model answer, the underlying biology, the clinical trial history, and this is important, the classic board traps.
Because they will try to trip you up.
Oh, absolutely. So we've got 3 distinct blocks today: intact localized disease, post-prostatectomy salvage, and then oligometastatic recurrence. Each one has a main case and a nice little board-style twist.
Sounds good. I'm ready.
Let us begin. We will start with Block 1, intact, unfavorable, intermediate-risk prostate cancer. I'll give you the initial presentation and workup for our first patient.
Okay, I'm taking notes.
Good. So a 66-year-old man is referred to your clinic after an elevated screening, PSA of 14.
Okay, PSA 14.
A digital rectal examination reveals a firm nodule in the right midgland, and it encompasses less than half of that right side.
Got it.
His systematic ultrasound-guided biopsy shows Gleason 4+3, which is grade group 3, in 3 of 6 right-sided cores, and then Gleason 3+3 in 1 left-sided core.
Okay.
Now, we obtain a multiparametric MRI of the prostate, which demonstrates a highly suspicious PIR8A5 lesion in the right peripheral zone. It measures 1.4 centimeters.
Any extraprostatic extension?
Good question. No definite extracapsular extension and uninvolved seminal vesicles.
Okay.
A next-generation PSMA PET scan is entirely negative for regional nodal or distant systemic disease.
Negative PSMA. Got it.
Functionally, he has well-controlled hypertension, he is sexually active, and he has a mildly elevated International Prostate Symptom Score, or IPSS, of 10.
Okay.
So, Doctor, how do you assess this patient, and what are the key clinical decision points?
Let me organize my answer.
Take your time.
So I always begin by anchoring my assessment to the core clinical inputs, right? Because those dictate the entire biological framework of the disease we're dealing with.
Right.
First, looking at his clinical examination, the digital rectal exam defines his clinical T stage. Because he has a palpable abnormality, but it's confined to one lobe and involves less than half of that right lobe, he is clinical stage CT2A.
Correct.
His PSA is 14, and his biopsy shows grade group 3 disease, meaning a Gleason 4+3. But I want to pause on that MRI for a moment because it's crucial here.
Let's hear it.
The MRI shows a PIRADS5 lesion. For a lesion to be categorized as a 5, it typically demonstrates, intense restricted diffusion on the ADC map.
The apparent diffusion coefficient, right?
Exactly. And that indicates high cellular density, which is very characteristic of aggressive tumors. So even though it is only 1.4 centimeters, its imaging characteristics make it highly suspicious.
I agree. What else from the imaging?
Well, importantly, the MRI shows no definite extracapsular extension and no seminal vesicle invasion, and that beautifully corroborates our clinical CT2A stage from the DRE. Furthermore, the negative PSMA PET scan effectively rules out gross nodal spread or distant metastases.
Right. And what about his functional status? Why do we care about that right now?
I was just getting to that. So an IPSS of 10 indicates mild to moderate baseline urinary symptoms, probably some frequency or urgency, and he is sexually active. These functional metrics are vital because they directly influence my treatment counseling.
Good. So what are the key decision points?
The key decision points here are establishing his accurate risk group assignment, selecting the optimal treatment modality, and if he proceeds with radiation, defining the exact intensification strategy.
Meaning what exactly?
Meaning specifically the dose, the fractionation, the integration of androgen deprivation therapy, and whether elective pelvic nodal irradiation is warranted.
I like how you systematically broke down the inputs there. And for you listeners at home, notice how the examinee did not just read the MRI report back to me.
Right, you want to show you know what it means.
Exactly. They explained what a PI Rades 5 finding implies biologically high cellularity, restricted diffusion. That is what examiners want to hear. But let us drill down into the staging and risk group now. Using the appropriate staging system and the current risk group framework, what is his exact stage and risk category? And I want you to explain the biological prognostic features you are identifying.
Sure.
I mean, I know what many listeners are thinking right now. He has a Gleason pattern 4, so why isn't he high risk? Or why isn't he stage I3A? Walk us through the board traps here.
Ah, right. So his clinical stage is CT2A N0M0. For treatment selection, the most important label to apply is NCCN unfavorable intermediate risk.
Unfavorable intermediate risk. Let us unpack exactly why.
Right. So I categorize him as unfavorable intermediate risk because he has grade group 3 disease, which is Gleason 4 plus 3, and he has more than one intermediate risk factor.
Which factors?
Specifically, the Gleason 4 plus 3 pathology combined with a PSA between 10 and 20, his was 14.
Right.
To be classified as favorable intermediate risk, a patient must have only one intermediate risk factor, absolutely no grade group 3 disease, and a limited volume of positive cores. He clearly does not meet those favorable criteria.
He definitely does not. Now, what about that staging trap I mentioned?
Yeah, if we're speaking strictly about the AJCC 8th edition prognostic stage group, this patient is stage IAs.
And the trap is?
The classic board trap is to accidentally call this stage IIA. In the AJCC system, stage IIA specifically requires a PSA of 20 or higher, regardless of the Gleason score. Because his PSA is 14, he remains in stage IA.
That is exactly the nuance required. For the listeners, Gleason 4 plus 3 alone makes a patient unfavorable intermediate risk, even if his PSA was 6.
Yeah, that grade group 3 pathology firmly places him in the unfavorable category.
Right. Never call a Gleason 4 plus 3 favorable intermediate disease in a high-pressure exam setting. So you got the stage. What is the major prognostic feature here?
The major prognostic feature driving his management is that predominant Gleason pattern 4.
What does that mean microscopically?
Under the microscope, pattern 4 represents fused, cribriform, or poorly formed glands. It has a high degree of genomic instability.
And clinical.
It has a significant propensity for micrometastatic spread compared to pattern 3. That predominant pattern 4 is what biologically separates him from a favorable patient and drives our need to escalate his therapy.
Perfect. Okay, let us move to the management recommendation. What treatment options would you discuss with this patient, and what is your preferred recommendation?
So I would inform the patient that both radical prostatectomy and definitive radiation therapy are standard of care curative options for his disease. It is critical to present both fairly.
Okay, play devil's advocate for me then.
Yeah.
Why would surgery be considered here?
Well, if he opts for surgery, the primary advantage is obtaining definitive final pathology. That tells us exactly what we are dealing with microscopically.
Are there any surgical caveats for this specific guy?
Yes, absolutely. I would emphasize that a pelvic lymphadenectomy must be nomogram-guided.
Meaning?
Given his unfavorable features, his risk of nodal involvement exceeds standard thresholds, so an extended pelvic lymph node dissection is mandatory to ensure adequate staging and regional control.
Very good. But you're a radiation oncologist.
Right, so my default recommendation, and the one I would strongly defend on the boards, is definitive radiation.
Give me the specifics.
Specifically, I recommend dose-escalated external beam radiation therapy combined with 4 to 6 months of androgen deprivation therapy, or ADT.
Okay. That is a clean, highly defensible answer for unfavorable intermediate risk disease. What is the rationale?
The rationale is grounded in robust randomized data, like the D'Amico and RTOG trials, which show a clear overall survival benefit from the addition of short-course ADT in intermediate risk disease.
And where is that benefit concentrated?
That benefit is heavily concentrated in this specific unfavorable subset.
Good. On the oral boards, guys, do not fall into the trap of claiming one modality is categorically superior for localized prostate cancer. State both standards objectively, then defend your chosen plan.
Right.
So let us talk about that ADT recommendation. Why are we giving hormones with radiation? What is happening at the cellular level? I do not just want to hear because the trial said so.
Okay, getting into the radiobiology.
Exactly. How does ADT biologically sensitize prostate cancer cells to radiation?
That is a fundamental radiobiology concept. Radiation therapy works primarily by causing double-strand DNA breaks in the cancer cells.
Mm-hmm.
Now, prostate cancer cells rely heavily on the androgen receptor pathway, not just for growth and proliferation, but also for DNA repair.
Tell me more about that.
Specifically, the androgen receptor regulates the expression of key genes involved in the non-homologous end joining repair pathway, like DNA PK.
So what happens when we give ADT?
When we introduce androgen deprivation therapy, we plummet the patient's testosterone to castrate levels. This deprives the androgen receptor of its ligand, shutting down that critical DNA repair machinery.
And then the radiation comes in.
Exactly. When the radiation comes in and shatters the DNA, the prostate cancer cell is uniquely vulnerable and cannot stitch itself back together.
Excellent breakdown of the mechanism.
Yeah, the ADT acts as a potent radiosensitizer, creating a synergistic lethal effect that is far greater than either modality used alone.
All right, since he chooses radiation, outline your radiation plan for the examiner. Use a structured approach to walk me through your simulation, your target volumes, your dose and fractionation, your ADT integration, and your key planning priorities.
So I like to use the mnemonic VDAN to structure this on the boards: volume, dose, ADT, and notes.
Okay, VDAN. Let's start with simulation.
Starting with simulation, I would simulate him supine with reproducible custom immobilization for the lower extremities.
I have the lower extremities.
To prevent any pelvic rotation, the internal anatomy is highly mobile, so preparation is everything.
What about bladder and rectum prep?
I require a comfortably full bladder, usually achieved by having him drink a specific volume of water prior to the scan. This acts like a balloon, pushing the small bowel superiorly and anteriorly, safely out of the high-dose radiation field.
Right. And the rectum.
Conversely, I require an empty rectum. A distended rectum would push the prostate anteriorly during simulation, and if the rectum is empty on treatment day, the prostate falls backward, potentially right out of the target volume.
Geographic miss.
Exactly. I'd also have 3 gold fiducial markers placed in the prostate prior to simulation to serve as rigid surrogates for daily image guidance. Finally, an MRI fusion is highly helpful and strongly recommended for precise prostate and seminal vesicle delineation.
Good. Let's move to volumes from your mnemonic.
For volumes, my clinical target volume, or CTV, includes the entire prostate gland and the proximal 1 to 2 centimeters of the seminal vesicles, as the MRI showed no distal involvement.
And the PTV.
For my planning target volume, or PTV, I use a 5mm expansion in all directions, except posteriorly, where I use a 3mm expansion to spare the anterior rectal wall.
That's a tight posterior margin.
It is, and it's entirely contingent on strong daily image guidance using both the fiducials and cone beam CT.
Okay, walk me through the dose and ADT components of your mnemonic now. What exactly are you prescribing, and what is the radiobiological justification?
For dose, my default is moderate hypofractionation. I would prescribe 60 gray in 20 fractions, which equates to 3 gray per fraction.
Why not standard fractionation?
The rationale here is rooted in the unique alpha-beta ratio of prostate cancer. Prostate cancer is believed to have a very low alpha-beta ratio, estimated to be around 1.5.
And what does that mean practically?
This means it is highly sensitive to the size of the daily dose. By using larger daily fractions like 3 gray instead of the traditional 1.8 to 2 gray, we can deliver a more biologically potent dose to the tumor.
While sparing normal tissue.
Right, while maintaining equivalent or even reduced late toxicity to the surrounding normal tissues like the rectum and bladder, because they have higher alpha-beta ratios. This approach is supported by large non-inferiority trials like CHFP and PROPHET.
Good. But wait, what about his baseline urinary function? He has an IPSS of 10.
Yeah, given his IPSS of 10, indicating some existing urinary symptoms, 60 gray in 20 fractions is the most defensible approach.
As opposed to what?
While ultra-hypofractionation, or SBRT, could be discussed selectively, with that baseline IPSS, a 5-fraction regimen carries a higher risk of acute urinary toxicity flare. Moderate hypofractionation is the cleaner answer here.
I agree. Moving to ADT.
Right. I would initiate therapy neoadjuvantly about 2 months prior to radiation to shrink the gland and downregulate those DNA repair enzymes we discussed. I will continue it concurrently and adjuvantly for a total duration of 4 to 6 months.
And what about the nodes? Are you treating the whole pelvis for this patient? I know there's a temptation to radiate everything just to be safe.
For the pelvic lymph nodes, I would not routinely treat them in this specific patient. The current randomized data do not justify making whole pelvis radiation automatic in unfavorable intermediate risk disease.
Which data specifically?
We have early results from the RTOG 0924 trial. That trial specifically evaluated the addition of whole pelvis radiation to prostate-only radiation, combined with short-course ADT in unfavorable intermediate risk and favorable high-risk populations.
And what did those results show?
Those early results, presented recently, do not show an overall survival benefit at 10 years.
Did they show anything?
They did show improvements in biochemical and distant metastasis-free survival, but because there is no proven overall survival benefit yet, and adding the pelvis increases the volume of normal bowel and bladder receiving dose, I still individualize pelvic nodal treatment.
So for this guy.
For a CT2A patient with a negative PSMA PET scan, the yield is simply too low to mandate it. Finally, for organs at risk, I would utilize standard protocol-based dose constraints for the rectum, bladder, bowel, femoral heads, and penile bulb derived directly from the CHHP trial to ensure safety.
Excellent use of the trial data to defend your stance. Listeners, the teaching point here is clear. For unfavorable intermediate risk disease, moderate hypofractionation plus 4 to 6 months of ADT without elective nodal radiation is still the most defensible answer on the boards.
Gotta keep it defensible.
Always. Now, let us talk about outcomes, surveillance, and toxicity. How exactly would you follow this patient? What defines a failure, and what acute and late toxicities must be explicitly discussed during your consultation? Well, let's make sure you understand the patient experience.
Sure. I would counsel the patient to expect excellent long-term disease control with a high probability of biochemical cure. Follow-up consists of serial PSA testing and rigorous symptom assessment every 6 months for the first 5 years, and then annually.
What's a critical counseling point regarding the PSA after radiation?
A critical counseling point, one that saves patients a lot of unnecessary panic, is explaining that after radiation, the PSA falls gradually over months, sometimes up to 2 or 3 years. It does not drop immediately to zero like it does after surgery.
Right. And what defines a formal failure?
I would educate him on the formal metric of failure, the Phoenix definition, which is a rise of 2 nanograms per milliliter or more above the absolute nadir PSA.
Anything else to warn him about?
I would also proactively counsel him about a PSA bounce. This is a benign, temporary rise in PSA that can happen 12 to 24 months after radiation. I like to describe it to patients as the immune system kicking up dust after the radiation battle. It does not mean the enemy has returned.
Great phrasing. And the toxicities. You are giving him radiation and systemic hormone deprivation.
Yeah.
What is he going to feel?
For acute toxicities during treatment, I prepare patients for radiation cystitis and proctitis. This manifests as urinary frequency, urgency, a weaker stream, dysuria, and potentially mild bowel urgency or loose stools.
And late.
For late toxicities, I discuss the small single-digit percentage risks of chronic urinary irritation, late rectal bleeding due to telangiectasias, and a gradual erectile decline over several years due to microvascular damage.
And we can't forget the ADT.
Exactly. Crucially, because we are using ADT, I must explicitly discuss its profound systemic effects. By dropping his testosterone, I will induce hot flashes, significant fatigue, a near total loss of libido, and temporary erectile dysfunction during the 4 to 6 months of therapy.
Anything metabolic.
I also counsel on metabolic effects, such as potential weight gain, muscle mass loss, and changes in lipid profiles. I would recommend regular exercise, specifically resistance training, to counteract the fatigue and muscle loss.
Very thorough counseling. You manage the medical and the psychological aspects well.
Yep.
Now let us introduce a board-style twist.
All right, lay it on me.
Same patient, same biopsy, showing Gleason 4+3, same MRI findings. But you get the PSMA PET scan back. It is not negative.
Uh-oh.
It shows a single, mildly avid 9mm left obturator lymph node. The rest of the scan is clear.
Okay.
How does this finding change your assessment, your biological framework, and your management?
Well, that finding changes the framework entirely. If that node is truly malignant, his stage immediately jumps from clinically localized disease to CN1M0 regional node positive disease.
Which means?
This makes him AJCC prognostic stage IVA. I must acknowledge this fundamental shift. This is no longer just unfavorable intermediate risk plus a little more disease. It represents a completely different biological state. The tumor has acquired the capacity to break out of the prostate capsule, invade the lymphatics, and colonize a regional node. My treatment backbone must escalate to match that threat.
How so?
I would now recommend definitive radiation to the prostate, the seminal vesicles, and the comprehensive elective pelvic lymph nodes, rather than just the prostate.
And the systemic piece.
Furthermore, my systemic therapy fundamentally changes. The ADT duration escalates from a short course, 4 to 6 months, up to long course, typically 18 to 24 months, because we are now treating high-risk node-positive disease.
Okay, I want to push back on that a bit. Would you add any other systemic agents based on this single node? Let's talk about the STAMPEDE trial. You're giving him abiraterone.
I would absolutely discuss further systemic intensification, specifically the addition of an androgen receptor pathway inhibitor like abiraterone. But, well, I would state my recommendation very carefully on the boards.
Why carefully?
Because the strongest data for abiraterone come from the STAMPEDE trials, which showed a significant overall survival benefit when adding abiraterone to long-course ADT and radiation. However, the patients in STAMPEDE were conventionally staged.
No.
They had bulky, CT-visible node-positive disease, or at least 2 out of 3 high-risk features. Applying that aggressive triplet therapy to a single PET-only node in a patient who is otherwise intermediate risk based on standard parameters is extrapolating the data.
Very true.
It is a very common modern scenario, but it is an extrapolation. I would offer it through shared decision-making, weighing the survival benefit against the added fatigue, hypertension, and hepatotoxicity of abiraterone.
Excellent nuance. And what about confirming the node? Are you sending a surgeon in there to biopsy a 9mm node just to be sure?
If the PSMA finding is equivocal and a biopsy is technically feasible and safe, it can be considered, but only if the result would materially change a major escalation decision, like committing this man to 2 years of chemical castration. However, I would not claim that a biopsy is strictly mandatory in every such case. A 9mm obturator node is highly suspicious, it is in the primary drainage echelon of the prostate, and PSMA has a very high positive predictive value.
So what's the bottom line?
If it looks like cancer and acts like cancer on a targeted molecular scan, we often treat it as cancer without demanding tissue, especially if a biopsy carries undue surgical risk.
Spot on. The takeaway for the twist here.
Yeah.
APET-only pelvic nodes should absolutely make you rethink the disease state and shift to a node-positive framework. But avoid rigid, one-size-fits-all systemic responses on the boards. Recognize aloud when you're extrapolating data from conventionally staged trials into the modern molecular imaging era.
Good advice.
Okay, let us transition to Block 2. Post-prostatectomy biochemical recurrence salvage radiation.
Moving along the timeline.
Yes, we are moving along the lifespan of prostate cancer, from intact disease to disease that has escaped the surgical bed. Here's the initial presentation. A 62-year-old man underwent a robotic-assisted radical prostatectomy 2 years ago. The final surgical pathology showed PT3A disease with extraprostatic extension, a Gleason score of 4+4, which is grade group 4, a positive posterolateral surgical margin on the right side, negative seminal vesicles, and 18 negative pelvic lymph nodes.
Okay, got all that.
His postoperative PSA nadired beautifully to below 0.1. Today, in your clinic, his PSA is 0.28, which is up from 0.18 3 months ago.
Right, it's rising.
Clinically, he is doing great. He's fully continent, uses 0 pads per day, and has experienced partial erectile recovery. So, examining, how do you evaluate this patient, and what are the key clinical and biological considerations?
So this is a classic scenario of a rising detectable PSA after a radical prostatectomy in a patient with significant adverse pathologic features. First, let us look at the numbers strictly objectively.
What do the numbers say?
If his prior value is 0.18 and today it is 0.28, he has technically not yet met the classic American Urological Association definition of biochemical recurrence, which requires 2 separate consecutive PSA values of by 0.2 or higher.
So do you just send him home?
Absolutely not.
Yeah.
Biologically and clinically, he is already well within the early salvage window, and that upward trajectory is what matters most.
Exactly.
Treating early salvage is like fixing a slow leak in a pipe before the basement floods. Waiting for the PSA to climb higher just to meet a rigid historical definition merely guarantees more water damage, a higher burden of microscopic disease, and a lower probability of achieving a secondary cure.
That is a fantastic analogy. The leak has started. Keep going with your assessment. What do those pathology features actually mean?
I note his adverse features from the operative report. He has extraprostatic extension, meaning the tumor biologically acquired the ability to digest through the prostatic capsule and into the periprostatic fat. He has grade group 4 disease, meaning entirely Gleason pattern 4, representing highly aggressive, poorly differentiated cells. And he has a positive surgical margin,
Which means
meaning the surgeon literally cut through tumor leaving microscopic cancer cells behind in the patient's pelvis. My immediate workup would include confirming the PSA trend, reviewing the pathology report in detail to see the exact length of that positive margin, checking a baseline serum testosterone level, and obtaining next-generation molecular imaging, ideally a PSMA PET scan.
What are you looking for on the scan?
To rule out macroscopic disease that has already escaped the pelvis.
Good. And clinically?
Finally, I would carefully assess his current urinary and sexual function. The fact that he is fully continent and has partial erectile recovery is a critical baseline because any salvage radiation we deliver will introduce new anatomical stressors on top of his established surgical baseline.
I'm glad you detailed the pathology. Too often, we just read PT3A as a string of text without visualizing the tumor invading the fat. Now let us tackle a major conceptual controversy.
Oh boy.
Should this patient have received adjuvant radiation immediately after his surgery 2 years ago, given all those adverse features? And what is the optimal PSA threshold for initiating the salvage therapy you are proposing?
Well, historically, based on older randomized trials like SWOG 8794, this patient would absolutely have been offered adjuvant radiation therapy within months of his surgery due to the PT3A disease and the positive margin.
Right, but what about now?
However, our modern standard of care has shifted dramatically. The current paradigm for the vast majority of patients is close observation followed by early salvage radiation upon biochemical recurrence, rather than routine adjuvant radiation.
What data solidified that shift?
This shift was solidified by the artistic meta-analysis, which compiled data from 3 major randomized trials: Radicals, RAVES, and Getug AFU17.
And what did artistic show?
The meta-analysis conclusively showed no event-free survival advantage for routine adjuvant therapy over a strict policy of close observation with early salvage radiation triggered by a rising PSA.
Which means what for the patient?
That means many men can be safely spared the urinary and bowel toxicity of unnecessary pelvic radiation if a microscopic recurrence never actually declares itself.
Right. Now, regarding timing.
Regarding timing, the data clearly show that earlier salvage is better. Current guidelines recommend initiating salvage treatment by a PSA of 0.5 or less. Given his adverse pathology at a PSA of 0.28 and actively rising, this patient is in the prime early salvage window right now.
Precisely. Early salvage is the standard, and the classic board error is waiting too long for the PSA to climb. Let us move to target volume and systemic intensification.
Okay.
The PSMA PET comes back negative. Do you add elective pelvic nodal radiation for this patient? Do you ADT, and if so, for what duration?
The key decision point here is the presence of high-risk biological features. Because this patient has grade group 4 disease, I would definitively recommend the addition of ADT.
For how long?
The minimum duration of ADT with salvage radiation in this setting is 4 to 6 months. Whether we should extend that duration closer to 18 to 24 months depends on a comprehensive review of his total risk picture.
What goes into that review?
We must evaluate his PSA doubling time, the fact that he has high-grade disease, and any genomic risk classifiers like a Decipher score, which I would order on his surgical tissue. If the Decipher score comes back high risk, that pushes me toward a longer duration of ADT.
Good. And what about the radiation field design? Are you treating just the surgical bed or the whole pelvis?
For field design, I anchor my recommendation heavily to the SP-Port trial, also known as RTOG 0534.
Tell me about SP-Porty.
The SP-Port trial was a massive 3-arm study that evaluated salvage radiation alone, salvage radiation plus short-course ADT, and salvage radiation plus ADT plus comprehensive pelvic nodal coverage.
And the results?
SP-Port established that prostate bed radiation plus short-course ADT is a highly effective backbone, showing superiority over radiation alone. Furthermore, the trial demonstrated an additional freedom from progression benefit when elective pelvic nodal coverage was added in appropriately selected patients.
That's true for our guy.
Given this patient's high-risk features, specifically the Gleason 8 disease and the PT3A status, treating the pelvic nodes is highly justified. My clean, defensible board answer is, proceed with salvage prostate bed radiation now, add 4 to 6 months of ADT at a minimum, and strongly recommend comprehensive pelvic nodal coverage.
That is a solid evidence-based stance. Outline your target volumes and planning priorities for this salvage radiation. And I want you to be specific about the anatomy. What is the most critical anatomical structure you must not miss when contouring a post-prostatectomy bed?
For the prostate bed clinical target volume, I strictly follow a consensus post-operative contouring atlas, such as the RTOG consensus guidelines.
That's hard, isn't it?
It is. Contouring a post-surgical bed is notoriously difficult because the anatomy has been fundamentally altered. The single most important contouring pearl is to ensure you do not miss the vesicourethral anastomosis.
Emphasize that. Where is it?
Anatomically, this is the critical junction where the surgeon pulled the bladder neck down deep into the pelvis and sutured it directly to the membranous urethra after removing the prostate. Because the prostate is gone, this anastomosis can sit quite low, right at the pelvic floor.
Why is it so critical?
It is a frequent site of local recurrence, particularly if there was an apical positive margin. Due to post-operative anatomical shifts, the anastomosis is the classic geographic miss in salvage planning if one is not meticulous.
Very true. And the nodes.
If I am including the pelvic nodes, I contour the standard elective pelvic nodal stations based on a standard atlas: the obturator, internal iliac, external iliac, distal common iliac, and presacral nodes.
What dose are you aiming for in the bed, and how does that negative PSMA-PET impact your decision to treat?
The typical prescribed dose to the prostate bed in a microscopic salvage setting is in the mid-60 gray range, standardly 64 to 66 gray. If there was a macroscopic MRI visible recurrence, I might boost that specific area up to 70 gray.
And the nodes.
The elective pelvic nodal dose would be standard, typically 45 to 50 gray. Daily image guidance with cone beam CT is absolutely essential to account for the dramatic daily variations in bladder and rectal filling, which can easily push the target out of the field.
Yeah, address the PET scan.
Crucially, regarding the negative PSMA-PET scan, I absolutely do not withhold salvage prostate bed radiation just because the scan is clear.
Why not?
Because at a PSA of 0.28, a negative PET simply means the volume of recurrent disease is below the physical resolution threshold of the scanner. It does not overrule the strong clinical pathologic signal, the rising PSA, and the positive margin that microscopic recurrence is present in that bed.
Excellent point. Rely on the biology, not just the pixels. Let us focus on the patient experience now. What are the unique toxicity considerations for salvage radiation after prostatectomy, and how specifically do you counsel this patient sitting in front of you?
Salvage radiation requires a very different and often more difficult conversation than intact prostate radiation. I am starting from a post-surgical baseline where the pelvic floor musculature, the neurovascular bundles, and the urinary sphincter have already been traumatized by surgery.
Right, so what's the big issue?
Continence is the absolutely paramount issue. The physics of radiation dictate that we will be delivering high doses directly to the vesicourethral anastomosis, which sits right next to the remaining urinary sphincter.
He's dry right now.
He is. This patient is currently dry and pad-free, which is fantastic. But I must explicitly tell him that there is a small but very real risk that salvage radiation could induce fibrosis, compromise that sphincter, and permanently worsen his urinary control. I would also discuss the acute risks of radiation cystitis, potential urethral strictures, and further decline in his already partial erectile function. Because I'm adding ADT, I also must counsel him about hot flashes, fatigue, metabolic changes, and the reality that ADT will result in a much slower and potentially incomplete recovery of any sexual function.
Okay, summarize that for the patient in the room. Give me the two-sentence elevator pitch.
You are doing very well functionally right now, which is great. I am recommending early salvage radiation because our data show that your cure rates are significantly higher when we act, while the PSA is still a tiny fraction of a number. However, I want you to fully understand the trade-off. Achieving that higher chance of cure brings some unavoidable additional urinary, sexual, and bowel risks on top of what you have already experienced from your surgery.
Clear and empathetic. Now for the twist in block 2.
Bring it on.
Same patient, same PT3A Gleason 8 pathology. But what if his PSA never nadired to undetectable after his prostatectomy? Let us say the surgeon called you and said, his PSA was 0.10 at 6 weeks post-op, then 0.12 at 3 months, and is now 0.18 at 6 months post-op. How does this persistent PSA change your underlying biological assumptions, and how does it change your urgency?
A persistently detectable PSA after surgery is a fundamentally different biologic beast compared to a delayed late rise after an initially undetectable nadir.
How so?
A delayed rise usually implies a few dormant cells slowly waking up. A persistently detectable PSA strongly suggests one of two things. Either there is a significant volume of residual local disease left behind in the pelvis at the time of surgery, or, more concerningly, there is early micrometastatic disease already circulating in the body that the surgery obviously couldn't reach.
It's much scarier.
It is. This scenario is universally considered much higher risk. My workup still mandates a PSMA PET scan and a careful pathology review, but my clinical urgency is massively heightened.
Are you watching it?
No, I would absolutely not sit back and watch his PSA to wait for a larger, more traditional recurrence threshold. I would move towards salvage radiation and systemic therapy immediately.
How does it impact your systemic therapy recommendation?
I would lean much more strongly toward extending the duration of ADT. A persistently detectable postoperative PSA is explicitly recognized as a high-risk feature in modern salvage guidelines.
What if the scan shows disease?
If his imaging showed macroscopic nodal or distant disease, that would shift the treatment framework entirely towards systemic dominance. But assuming no macroscopic metastases are seen on the PET, the key teaching point is that a persistent PSA pushes me toward earlier, not later, salvage intervention, combined with a robust, prolonged course of systemic therapy.
Exactly right. Persistent PSA implies disease that was never fully cleared. You must act decisively.
Right.
Let us move to Block 3, oligometastatic recurrence after prior definitive radiation. We are now entering the final stage of the prostate cancer lifespan.
Systemic spread.
The hardest part. Definitely. Here is the case presentation. A 70-year-old man was treated 5 years ago for high-risk prostate cancer. His prior treatment was definitive external beam radiation to a full dose of 78 Gray to the prostate, along with 24 months of ADT.
Okay, 78 Gray. That's important.
Very. His nadir of PSA was undetectable during that treatment, and he did well for years.
Yeah.
His testosterone has since recovered to a normal physiological level.
Good.
However, over the last year, his PSA has steadily risen from 1.2 to 2.8 and now to 3.5. You order a PSMA PT scan.
And what does it show?
It shows 2 mildly avid left external iliac lymph nodes, both measuring under 1 centimeter, and a single intensely avid left posterior rib lesion.
3 lesions total.
Yes. A technetium bone scan shows no other sites of disease. He is completely asymptomatic with an ECOG performance status of 0. How do you classify this patient, and what is your initial assessment?
Well, first, this is a clear clinical recurrence after prior definitive radiation. He meets the Phoenix definition of biochemical failure, a rise of more than 2 nanograms per milliliter above his nadir.
True, but biochem is just the start.
Right. We have moved beyond biochemistry. He now has 3 discrete PSMA avid metastatic sites.
So what's the label?
On the boards, I would articulate his disease state exactly like this. This is metachronous, oligorecurrent, hormone-sensitive prostate cancer.
Break that down. Why those exact words?
That specific label matters immensely as it unlocks the correct treatment algorithms. It is metachronous because the spread is happening years after his initial definitive local therapy, as opposed to synchronous or de novo metastatic disease found at initial diagnosis.
Okay, oligorecurrent.
It is oligorecurrent because he has a limited number of visible lesions 3, which fits standard oligometastatic definitions, usually defined as 3 to 5 lesions.
And the most important part?
Most importantly, it is hormone sensitive because his serum testosterone has recovered to normal levels. This is not metastatic castration-resistant disease. Those precise clinical distinctions determine which randomized trials apply to him and which treatment pathways are clinically relevant.
That is exactly how you must frame it. Listeners, pay attention to that phrasing. In metastatic prostate cancer cases, you must label the exact disease state before you offer a single treatment.
Yeah, you can't just guess here.
Right. If you get the label wrong, if you confuse hormone-sensitive with castration-resistant, or synchronous with metachronous, your entire subsequent answer will be wrong, and the examiner will fail you on that section.
High stakes.
So, based on that precise label, what treatment do you offer this metachronous oligorecurrent patient? Walk me through your clinical reasoning.
I would offer metastasis-directed therapy, specifically stereotactic body radiation therapy, or SBRT, to all 3 visible lesions.
Why? What's the biology behind that?
The oligometastatic paradigm, first hypothesized by Hellman and Weichselbaum, suggests there is an intermediate biological state between localized disease and widely disseminated polymetastatic disease.
Can you use an analogy?
Think of it like pulling a few early weeds from a garden rather than having to spray the entire lawn with toxic herbicide.
I like that. What data supports this?
We now have strong phase 2 data from trials like STOMP and Oriole, as well as their pooled long-term analysis, which support the use of metastasis-directed therapy, or MDT, in appropriately selected oligorecurrent hormone-sensitive patients.
What imaging did they use?
STOMP used choline PET and Oriole used PSMA, but both demonstrated that MDT can significantly delay disease progression and, crucially, delay the time until the patient requires lifelong palliative systemic therapy.
What about the Extend trial?
Furthermore, the Extend trial supports the concept that MDT can provide a significant progression-free survival benefit when used alongside intermittent hormone therapy.
I am glad you put up the systemic piece. Let us push on that. What about the systemic therapy for this specific patient? Are you intensifying everyone with triplet therapy just because they have metastatic disease?
The systemic question is the most nuanced part of this scenario. I would absolutely discuss restarting ADT with him, but on the boards, I would not present that as one rigid, universal rule for every single oligometastatic patient.
Well, yeah.
In highly selected, well-informed men who strongly prioritize avoiding ADT side effects, perhaps because they had a terrible quality of life during their prior 24 months of hormones, MDT alone can be utilized as a strategy to defer systemic therapy for a period of time.
And for others?
In others who prioritize maximal progression delay, MDT combined with restarting ADT is a very reasonable and supported approach.
What about adding something like enzalutamide?
Regarding additional androgen receptor pathway intensification, such as adding an agent like apalutamide or enzalutamide, that should be discussed in conjunction with medical oncology. However, I would frame that as an individualized and more extrapolative strategy in this metachronous low-volume setting.
Because?
The massive trials proving the benefit of those potent agents were largely done in de novo, high-volume metastatic disease.
So what's your ultimate recommendation?
So my ultimate recommendation is MDT to all 3 lesions, coupled with a shared decision-making process about restarting ADT, depending heavily on his personal goals, his prior tolerance of hormones, and his risk tolerance.
A very balanced, sophisticated approach. You demonstrated that you know the data, but also that you know the limits of the data. Now, outline your SBRT planning approach for the 2 pelvic nodes and the rib lesion.
Okay.
And pay careful attention to his history. I want to know exactly how you deliver this safely.
For the 2 left external iliac nodes, I would meticulously fuse the diagnostic PSMA PET scan to a non-contrast planning CT. I would contour the visible nodal targets as my gross tumor volumes.
What margins are you using?
I would then use tight, image-guided margins, typically 3 to 5 millimeters, to create the PPDs. In an MDT setting for recurrence, my approach is strictly focal. I treat only the macroscopic disease.
No elective nodal radiation?
I do not quietly convert the plan into an elective whole pelvis nodal radiation field unless I explicitly state my clinical rationale for doing so, which I am not in this case.
Okay, now the rib.
For the left posterior rib lesion, the anatomy dictates the technique. I would utilize rigid body immobilization and carefully assess respiratory motion using a 40CP simulation.
Right, breathing is an issue.
A rib lesion moves with breathing, so I must create an internal target volume, or ITV, that encompasses the tumor's full range of motion. The exact dose and fractionation for the rib will depend on its precise location and proximity to nearby organs at risk.
What's the goal?
The core principle is delivering an ablative dose, something like 30 gray in 3 fractions, while strictly adhering to spinal cord, lung, and chest wall constraints to prevent rib fracture or pneumonitis.
You mentioned his history briefly, but I need you to address the elephant in the room.
Yeah.
Look at his prior treatment record. What is the single biggest safety hazard in this case?
The critical board point here is his prior definitive radiation to 78 gray to the pelvis.
Yes, it is.
Because he has had prior high-dose pelvic radiation, I must generate a composite dose assessment before I even consider treating these external iliac nodal lesions.
Why? What's the danger?
The surrounding normal tissues, the bowel, the bladder, the rectum, and the regional nerves hold memory of that prior 78 gray. We use the concept of biologically effective dose, or BED, to calculate the cumulative stress on these tissues, focusing heavily on late-effect alpha-beta ratios of 3.
And what happens if we ignore it?
Adding an ablative SBRT dose to a pelvic node might easily push the cumulative dose over the tolerance threshold, leading to severe, irreversible late toxicity like a bowel fistula or a nerve plexus injury.
exactly.
Reviewing the composite dose plan, fusing the old plan to the new simulation is a mandatory safety step. If the composite dose is too high, I cannot safely deliver the SBRT, and we must rely entirely on systemic therapy.
Excellent. In any previously irradiated pelvis case, composite dose review is mandatory. Never offer SBRT blindly. Moving on, what outcomes do you realistically expect from this approach, and how do you follow this patient longitudinally?
I'm very transparent with the patient that the primary goal of this oligometastatic paradigm is usually not to promise a permanent cure.
What is the goal then?
The realistic biological goal is to prune the macroscopic disease, delay further progression, preserve his quality of life, and extend the interval before we must resort to broader, more toxic systemic escalation.
Do they stay progression-free forever?
While some patients do experience a durable benefit and prolonged disease-free intervals, microscopic disease is almost certainly present elsewhere in the circulation.
So how are you following him?
I would follow him closely with serial PSA checks, usually every 3 months initially. Imaging is individualized based on PSA kinetics and symptoms. I would repeat a PSMA PET scan only when the result would actively change my management, for example, if his PSA rises significantly again.
No routine 3-month scans.
I would not present a 3 to 6 month PET scan as mandatory routine surveillance in an asymptomatic patient, as that induces scanxiety without proven benefit. Finally, if he later develops a small number of new sites, serial MDT may still be a reasonable option depending on the velocity of progression and his clinical status.
Well said. Oligometastatic management is inherently longitudinal. You are managing a chronic disease state. Now, the final twist to the session.
Let's hear it.
Same patient, same 3 PSMA avid findings on the scan. But this time, when you check his labs, his serum testosterone comes back at 15 nanograms per deciliter, which is well below the current castrate threshold of 50.
Wait, 15?
Yes. Let us say he actually stopped his ADT a year ago, but his testes simply never recovered function. What changes in your biological assessment and your management?
Okay, this changes everything about the systemic framework. Progression, meaning rising PSA and new PET-avid lesions, is now occurring in the setting of castrate testosterone levels.
Which means?
Therefore, this is no longer hormone-sensitive disease. The tumor has mutated, likely through androgen receptor amplification or splice variants like ARV7, to grow independently of normal testosterone levels.
So what pathway is he on?
I must immediately transition to managing him on the metastatic castration-resistant prostate cancer, or mCRPC, pathway. Crucially, I must ensure we keep his foundational ADT running in the background.
Even though his testosterone is already low?
Yes. Even though his testosterone is naturally low right now, we must maintain that castrate environment medically to suppress any remaining. Pluvicto works by binding a beta-emitting radioactive isotope directly to the PSMA receptors on the cancer cells, delivering targeted radiation at the cellular level. It is important to note for the boards that it is no longer accurate to describe Pluvicto strictly as a post-taxane therapy.
Right.
The FDA label expanded to include some patients who have progressed after pathway inhibitor therapy and for whom it is appropriate to delay taxane chemotherapy.
And what about the MDT radiation we discussed earlier?
While SBRT can still play a complementary role in targeting symptomatic or rapidly growing oligoprogressive sites in mCRPC to delay a change in systemic therapy, MDT is absolutely not a substitute for escalating systemic therapy in this castration-resistant setting.
That is the crucial distinction. If the disease is progressing while testosterone is at castrate levels, you must switch to the mCRPC playbook immediately. Do not try to treat mCRPC with local radiation alone.
Right. Systemic disease needs systemic treatment.
That completes our 3 prostate cancer mock oral blocks. We have traced the disease from intact intermediate risk to microscopic failure in the surgical bed, all the way to macroscopic oligometastatic recurrence and castration resistance.
It's quite a journey.
It really is. Let me leave you with a rapid review of the highest yield, board-ready takeaways from today's session.
I'm listening.
From Block 1, unfavorable intermediate risk disease requires dose-escalated radiation plus 4 to 6 months of ADT if the patient chooses radiation. The biology demands it to prevent DNA repair. If surgery is chosen, a lymphadenectomy must be an extended, nomogram-guided dissection, not simply assumed. Elective pelvic nodal radiation in unfavorable intermediate risk disease remains an individualized decision based on the lack of overall survival benefit in the early RTOG 0924 data.
Got it.
From Block 2. Early salvage radiation is the modern standard of care over routine adjuvant radiation for the vast majority of patients post-prostatectomy, thanks to the artistic meta-analysis. Salvage works best when initiated at a low PSA, ideally under 0.5, fix the leak before the basement floods.
Love that analogy.
In patients with higher-risk pathologic features, combining prostate bed radiation with ADT and giving strong consideration to elective pelvic nodal treatment based on SB port is a clean, defensible answer. And anatomically, never miss the vesicourethral anastomosis when contouring the bed.
Classic geographic miss.
Exactly. And finally, from Block 3, every metastatic prostate cancer case must start with correct disease state labeling. In metachronous oligocurrent hormone-sensitive disease, metastasis-directed therapy is supported by STOMP and Oriole data, while the systemic therapy question remains individualized.
Right.
However, if there is progression with castrate testosterone levels, you are dealing with MCRPC. You must transition frameworks, escalate systemic therapy, and continue foundational ADT. Furthermore, never radiate a previously treated pelvis without a rigorous composite dose review.
Essential for safety.
It is. The oral boards are often won or lost in the first 30 seconds of your response. Get the biological disease state right, state the standard pathway confidently, and then layer in the complex nuance and trial data only after your foundation is solid. Complete practice oral boards at radoncSmartLearn.com and subscribe to Rad Onc Smart Review for our next episode. Thanks for tuning in.